All right, everybody, Dr. Rafich here from Vet Triage. If you follow this channel, you'll notice that I've been posting videos less often. So we're going to be going to once a week and on Mondays. That'll allow me to take a bit more time dissecting these articles and not have to speed through them as much. My goal of the channel was to just give an overview to pet owners and veterinarians without going into the nitty gritty. But because Vet Triage is very busy and I have many other responsibilities regarding that platform, I think that if I can spend more time going into a little bit of a deeper dive, just a little bit, not too crazy, with these articles, then it'll add more value to the audience and also allow me time to not have to churn out videos every single day. So I went from 7 days a week to 5 days a week because weekends, the numbers on my channel for weekends were not very high. And it seems like Mondays in general are fairly popular days of the week to watch videos, although it's kind of all over the place in general. So we're going to try every Monday and we'll see how that goes for the next few months. And hopefully that'll prove to be useful for folks. And by the way, also, it seems that the majority of people who watch these videos are not subscribed to the channel. So, subscribe and help me out. Okay, so we're going to go through the second to last article in the 2021 edition of Veterinary Surgery. We're going to be talking another cadaver study in dogs. This is intestinal surgery. The influence of crotch suture augmentation on leakage pressure and leakage location during functional end-to-end stapled anastomoses in dogs. So let's talk about that title. So crotch suture augmentation. So here are the 4 techniques they're going to use. And when they say crotch, they literally mean like a pair of jeans. The crotch area, that's where they have this V, where the intestines are where the attachment of the intestines ends. So this is the anastomosis site here. So what the doctor has done is they've removed the bowel that was diseased. So let's say there's a bowel that goes from here to here. They remove that, and instead of performing an end-to-end anastomosis, this is a functional end-to-side anastomosis. So you have here the two sides of the intestinal tract with staples, and the crotch area here, they're testing the augmentation of it by adding sutures. So then they have here influence of crotch suture augmentation on leakage pressure. So that's how much fluid or air is required to be injected into here to see leakage. And then also looking at not only the pressure but that is required to create that leakage, but also where does the intestines leak from? That's leakage location. And then the functional end-to-end stapled anastomoses in dogs. This study comes out of the University of North Carolina as well as Purdue in Indiana. The objective is to determine the influence of anastomotic crotch suture augmentation on leakage pressures and leakage location following intestinal functional end-to-end stapled anastomosis in dogs. And it's going to be hard for folks to see this. I don't know if I can actually want to mess this up or not. Here we go. So we'll go through each of these now that I blew it up. This is an ex vivo, meaning outside the body, randomized experimental study, 3 adult dogs. The dogs were assigned to 4 treatment groups. So the first one was no crotch suture. That's this one here. So you can see here, functional, this is picture A, functional end-to-end staple anastomosis with no crotch suture augmentation. So they didn't put any suture material here. B is simple interrupted crotch suture. So they place 1 suture right there. So that's B. So if you go here, B, simple interrupted crotch suture placement equidistant between the antimesenteric border of the opposed jejunal limbs. And then you have C. C is the 2 simple interrupted crotch sutures. So they just doubled it, 2 sutures here. And C, 2 simple interrupted crotch sutures with either suture placed laterally on opposing jejunal limbs, 3 millimeters distal to the end of the longitudinal staple line. And then finally, D is a simple continuous crotch suture augmentation. So you can see here they placed a simple continuous pattern here in the crotch area. So that is D, simple continuous crotch suture started 3 millimeters distal to the end of the longitudinal staple line with suture bites placed 2 to 3 millimeters apart with 2 bites placed on either side of the crotch and a single bite equidistant between the opposed jejunal segments. So these are the 4 that we're studying here for this paper. They used 3-O polydioxanone. They tested the initial leakage pressure and maximum leakage pressure. The results found that initial leakage pressure was greater after placement of the 2 simple interrupted crotch sutures. So that's this one here, 37.8 millimeters of mercury, and also the simple continuous, that's this one here, which was 47.6, and those are both greater than no crotch suture at 27.1, and also compared to the simple interrupted suture, this one here. Maximum leakage pressure was greater in specimens including the simple interrupted, that's this one, the 2 simple interrupted, that's this one, and the simple continuous. All 3 of them, then those without a crotch suture, which is this one. Leakage occurred at the anastomotic crotch in 8 out of 12 in this category, 6 out of 12 with this one. Yep. 11 out of 12 with this one, and 12 out of 12 with this one. Conclusion, augmentation of the functional end-to-end stapled anastomoses with the 2 simple interrupted and the simple continuous increase the initial leakage pressure and decrease leakage from the crotch, while all methods of anastomotic crotch augmentation increased the maximum leakage pressure. So clinical significance, augmenting the functional end-to-end stapled anastomoses in dogs with crotch sutures improved the resistance of the anastomosis to leakage. Placing 2 sutures or simple continuous pattern was superior compared to placing 1 suture. I'm a little bit confused by the end-to-end because to me this clearly is side to side. So I'm not sure if that was just one big oversight or if I'm just missing something with this. So just keep that in mind for folks who are interested in this. Okay, introduction. Hand suturing is one option. Surgical stapling is another option. Circular stapling equipment is another option. And bipolar vessel sealing device is an option for anastomoses in dogs. Foreign body obstruction, ischemia, intussusception, necrosis, infiltrative disease, or cancer are all reasons to perform the surgery. Dehiscence can occur in up to 13% of dogs, with mortality rates up to 85%, very high. Small intestinal leakage occurs during the lag phase of intestinal healing, which happens 3 to 5 days following surgical intervention. There's been no difference between techniques used for anastomotic creation. The advantages of a functional end-to-end anastomosis include shorter surgical time, decreased requirements for manipulation of the bowel, consistency of staple placement, higher initial wound strength, decreased inflammation and necrosis, and improved blood supply. The functional end-to-end stapled anastomosis also makes it possible to deal with discrepancies in luminal diameter between opposed bowel segments. Again, I'm just not sure that they're categorizing this correctly. I don't know. Anyway, the creation of a functional end-to-end stapled anastomosis between opposed jejunal limbs can be performed with a linear gastrointestinal anastomosis stapling device, which is the GIA, that creates a longitudinal staple line. You can use a GIA or a thoracoabdominal stapling device, which is a TA. It's then used across the top of the anastomosis to complete the functional end-to-end stapled anastomosis, thus creating a transverse staple line. Modifications and technique refinement related to this surgery have led to recommendations for partial offset of the staple lines formed by each side of the longitudinal staple line. You can also have modifications and technique refinement by having partial offset of the staple lines formed by each side of the longitudinal staple line. You can also use serosal patch supplementation. You can use sutured oversew with the transverse staple line. You can place a crotch suture to control tension and prevent separation of opposed jejunal limbs to increase leakage pressure and reduce tension. In a retrospective study, oversewing of the transverse staple line prevented the occurrence of dehiscence and leakage. Placement of a crotch suture is routinely performed to prevent separation and oppose the antimesenteric jejunal surfaces. All right, materials and methods. The cadavers weighed between 30 and 32 kilograms. They had 96 jejunal segments used for the creation of 48 functional end-to-end stapled anastomoses. They used a 60 millimeter GIA stapling device, handpiece, and it was loaded with a blue 3.8 millimeter simple cartridge. Longitudinal staple lines were then visually examined and checked to ensure correct staple closure, and then partially offset as previously recommended. As the transverse staple line following the functional end-to-end stapling anastomosis has previously been reported as the most common site of leakage, the end of the anastomosis was occluded using Carmalts. Another straight Carmalt was placed oriented 180 degrees to the first, ensuring at least 1 centimeter overlap between the jaws of each instrument, and then they attached stay sutures, which were then cut with scissors. Then we have the 4 groups. No crotch suture, placing a single simple interrupted suture, placing 2 simple interrupteds, and then a simple continuous. And that's in the picture that we have there on the screen. They use 3-0 polydioxanone, which is PDS, with a swagged on taper SH 22 millimeter half taper needle, and they use square knot followed by 3 throws. Right off the bat, so 3-0 PDS is what we will commonly use, although typically dogs and cats for small intestine we're using 4-0 PDS. I usually use 3-0 for stomach, so it's a little bit big for this study, I think. And then also square knot. My first throw is usually a surgeon's throw, and then I follow it up with square knots. So that's also a bit on the weaker side here. A surgeon's knot is going to be stronger. And they only had 3 throws, where I normally go like 3 to 5, depending. So that's some variation there. This seems kind of weak, in my opinion, compared to what surgeons typically do. However, the fact that they had still pretty good results shows that even with a square knot and 3 throws, it still works. And I know a lot of surgeons that use square knots only for small intestine and only have 3 throws. Okay, results. Initial leakage pressure was greater after placement of the, so now they use the abbreviation, so we have to go back here. The 2 simple interrupteds and the simple continuous, compared with no suture or 1 suture. There was no difference in initial leakage pressure between no suture and 1 suture. The initial leakage pressure was greater after placement of the simple continuous compared with 2 sutures. The maximum leakage pressure was greater when augmented with the 2 sutures and the 1 suture as well as simple continuous when you compare to no suture. So when you can look at no suture, the initial leakage pressure was 27.1, maximum leakage pressure 41.8. When you look at a single suture, the initial leakage pressure is 33, maximum 70.5. 2 sutures, initial leakage pressure 37.8, maximum 75.3. And then simple continuous, initial leakage pressure of 47.6, maximum 100.6. The location of the leakage occurred in the longitudinal staple line or the sutured crotch. For the no suture group, leakage occurred at the crotch, which was at 67% of the cadavers, and the longitudinal staple line at 33%. Leakage with the single suture occurred in 50% at the crotch, and longitudinal staple line 50%. In the 2 suture and simple continuous, it occurred at the longitudinal staple line 92% and 100% respectively. All right, discussion. To prevent separation and maintain opposition of the anti-mesenteric jejunal surfaces, you add a crotch suture to increase initial leakage pressure and maximum leakage pressure while decreasing the leakage occurrence. Among those evaluated, placing 2 sutures and a simple continuous was better than 1 suture. Stapled anastomosis has an odds of postoperative dehiscence lower than those with hand sewn. In a recent study, 60% of functional end-to-end stapled anastomoses that received an oversew of the transverse staple line and 52% of non-oversewn functional end-to-end stapled anastomoses were augmented with a crotch suture. So it's like half the surgeons will augment it with a crotch suture in previous studies. In live dogs free from gastrointestinal disease, normal peristaltic pressures are recorded to be 6 to 25 millimeters of mercury, with fluctuations in intraluminal pressure occurring due to the occurrence of peristaltic contractions or migrating myoelectric complexes. with initial leakage pressures of over 25 millimeters of mercury, suggests that all techniques, regardless of suture pattern used, may effectively create a jejunal anastomosis that is able to withstand physiologic intraluminal pressures encountered in clinically normal dogs devoid of GI disease. So that's the idea here. Similar to the other video we had last week, there's a normal physiologic pressure, and when these studies test the pressure, they go way beyond that. The transverse staple line created using either a TA or GIA stapling device is the most common site of dehiscence and leakage. The crotch region at the base of the longitudinal staple line between jejunal limbs has been reported to be the area of the highest tension. The use of 2 sutures and simple continuous increased the initial leakage pressure by 1.2 and 1.6 times respectively compared with no suture. You can control the tension applied to the construct to a greater degree at the base of the longitudinal staple line upon luminal filling compared with no suture. You can create an area of even tension distribution around the base of the jejunal anastomosis encountered during luminal filling compared with the use of 1 suture. Recent publications, both ex vivo and in vivo canine models, reported the importance of oversewing the transverse staple line during the functional end-to-end stapling anastomosis to increase initial leakage pressure and reduce dehiscence. No occurrence of intestinal leakage compared to oversewn functional end-to-end stapling anastomosis, where about 15% of the stapled anastomosis dehisced. The mortality rate was 14% in that study. In healthy dogs devoid of GI pathology, the maximum intraluminal pressure rarely exceeds over 40 millimeters of mercury. Normally, obstruction of the stoma of the stapled anastomosis is a potential long-term complication of functional end-to-end stapling anastomoses, with obstruction known to cause acute rises in intraluminal pressure caused by luminal distension or RAD to the site of the obstruction. Hydrostatic pressures or RAD to the area of luminal compromise can reach up to 44 millimeters of mercury. If the cause of obstruction at the functional end-to-end stapling anastomosis site is not addressed or alleviated, then you get venostasis, edema of the intestinal wall, and vascular compromise, which turns into ischemia, necrosis, perforation. And it's been shown in studies that foreign body obstruction is a risk factor for dehiscence. Using the simple continuous pattern, you had a maximum leakage pressure that was 1.3 times, 1.4 times, and 2.2 times greater than using 1 suture, 2 sutures, and no suture, respectively. 42% of no suture constructs, there was leakage at less than 40 millimeters of mercury, which shows the importance of adding the suture following this surgery. Peritonitis can have mortality rates up to 83%. Compared to the transverse staple line, which is an everting closure, the longitudinal staple line is inverting and is more resistant to leakage. Leakage occurred predominantly from the anastomotic crotch of the functional end-to-end stapled anastomosis in 67% and 50% of no suture and single suture constructs, respectively. In the 2 sutures and the simple continuous suture groups, over 90% of leakage was observed along the length of the staple line created by the GIA stapling handpiece, which tells you that the crotch area was protected with those techniques. Based on these results, the 2 suture and simple continuous is superior. So issues with this study: this is ex vivo, so it wasn't inside live animals. They did not evaluate the jejunum with histopathology or scanning electron microscopy. They used smaller dogs here, so that's also a problem with the study. None of these animals had abnormal GI disease or abnormal blood work or anything like that. You could also test out different suture patterns like cruciate sutures, for example, and other supplemental techniques like Augmenting, serosal patch, surgical sealants, or buttressing materials, all of which were not evaluated in the study. You can use air or saline to detect leakage. So here they use saline. We don't know about air. But in conclusion, augmentation of functional end-to-end stapling anastomoses with 2 sutures or simple continuous increase initial leakage pressure and decrease the occurrence of leakage from the anastomotic crotch whereas all methods of crotch augmentation still increase the maximum leakage pressure. So you want to augment these surgeries with crotch sutures to improve resistance to leakage, and ideally either using 2 sutures or simple continuous. So yeah, so other problems with the study, of course, you always want a higher sample size, but this is a good number considering it's cadaver anyway. And I just still question, maybe it's just my misunderstanding of end to end versus side to side with this repair. But regardless, for pet owners, realize that there's always improvements being studied when it comes to intestinal surgery. And so, we have very high success rates, but when there is leakage, it is debilitating. And then for veterinarians who are dabbling with staple devices for anastomoses, since in general they tend to be better anyway compared to hand sewn, you can look at using GIEA and TA stapling devices with this technique, and then of course augmenting it with a crotch suture. It won't take that much time to add a suture anyway to it, so it seems like it's worth doing. Plus, you can also augment that with any other augmentation techniques you want to do, like almost a mental patch or serosal patches, things like that. All right, guys, thanks so much. We'll see you in the next video. Take care.